Hello, my name is Dobbin Chow. Um, I'm the program director here at the University of Maryland Medical Center Midtown campus for the Internal Medicine Residency program. Hope that this is the right link and you are dialed in for the right program. I know that you all are looking at the dozens of program links and websites during this busy season. So I greatly appreciate the time that you've devoted to doing this. Relax, sit back, get a cup of coffee in your hand or a glass of wine, whatever works for you. This is going to take a better part of an hour, hour and a half, perhaps. It's a little bit detailed. I apologize for the duration. I'll try to go through it in a most expedient manner that I can. I realize that it's a lot of material. But I want to try to be complete and then give you as much information about our program as possible. And because I want you to be in the position to make informed decisions regarding where you will do your training over the next 3 years. Hopefully, this will address some of the questions that you all may have. Okay, so let's go ahead and get started. This is a map of Baltimore. We're located right in right where the star is in this map. We're sort of at the confluence of several highways. 95 North goes up to Philadelphia. 95 South goes to Washington, D.C. Route 83 goes up in the northwest towards Harrisburg, Pennsylvania. And for all the world, it looks like we're at the confluence of these highways. If you look a little closer, this is Route 83, which is this highway running diagonally. And these blue dots are apartment buildings where residents have lived in the past. And this is where our hospital is. And so many residents, they live nearby within walking distance of the hospital. And this area is called the Midtown area. There's a this area to the north is largely a college campus. It's the Maryland Institute College for Art, and over here is there's a lot of things associated with the arts located in this Baltimore Midtown region. But people can access our hospital not just by living close by and walking, but also there's a light rail, which is a surface trolley that runs north-south. The northmost station is located in a suburb called Hunt Valley, and the southernmost station of light rail is located right in the Baltimore Washington airport. Baltimore also has one subway line called the Metro, and the westernmost stop on the Metro line is at a suburb called Owings Mills, and then the terminal station in the east is right at Johns Hopkins Hospital. So we're right on the subway stop as well. This is called State Center. So people can access our site from public transportation, from the suburbs, or folks can live nearby. This is the downtown Inner Harbor area. So we're about maybe a mile and a quarter from the downtown Inner Harbor area. It's a busy area, a lot of businesses there. Over here on the left of this picture is the National Aquarium, which is a tourist attraction. But there's a lot of restaurants and clubs and other distractions from our resident studies in this downtown area. Meanwhile, we're located close to the Midtown Arts District, And this is the Walters Art Museum, which is about 3 or 4 blocks away. This is the Meyerhoff Symphony Hall, which is just located right behind our hospital, about maybe 2 blocks away. A wonderful venue for music. The Baltimore Orchestra plays there. This is the inside of the Meyerhoff. It's a wonderful venue for music. Now, each year there's a big festival in this region called Art Fest. It's the country's largest art fair. Unfortunately, they have it in the summertime, and it's usually hot and muggy. But it's quite a busy and festive fair. I told one of my friends I'm coming here to work, and they said, "Oh, great! I finally have parking for Art Fest." So this is MICA, Maryland Institute College for Art, and we have we essentially abut their campus, which is terrific, because we have young students who go to that campus. They might utilize our Center for Healthcare. The faculty also live in the area. This neighborhood that the art school is located in is called Bolton Hill, which is it's a nice neighborhood in the city. The Lyric Performing Arts Center is about 3 blocks to the north of us, and there they have different music venues and also opera. So I try to interest the residents in this venue for their evening activities. This is the library, the School of Medicine library. It's located at the School of Medicine. It's a large facility, and residents can have access to it. Very comprehensive in its collections. Meanwhile, there's let me get you up to date about some background information about our hospital, and give you a sense for how we came to be and how we became integrated with the University of Maryland medical system. So this hospital was formerly known as Maryland General Hospital. It's been here at this site for over 125 years. We're the original MGH. No, we weren't, but I guess we're the second MGH. And it's been proud to serve this community. And it's a diverse community. There's people associated with the arts who live in this region, who utilize this campus for the healthcare. There's also patient communities to the west, which are largely underserved areas. They utilize this campus for the healthcare. There's also just to the north of us, there's state office buildings, and those state employees will utilize this campus for the healthcare. So it's a diverse set of communities, and we're proud and honored to serve those communities over the years. Now, there's so it was the hospital did well until the 1980s. This was a challenging time for hospitals all over the country. This was because in about 1982, 1983, the Medicare changed its reimbursement paradigm from one in which you were paid fee for service to one in which you were paid you were paid for a diagnosis, DRG reimbursement paradigm. So what does that mean? That means in the past, you provided a service to a patient, you billed Medicare for that service, and Medicare would pay. So the more service that you provided, the more reimbursement you would get. And so Medicare realized that wasn't a good approach. So it changed to one in which they would pay for a diagnosis. If you were hospitalized with heart failure, for example, Medicare would give you one allotment of funds to pay for that hospitalization, and whether you kept the patient in the hospital for 10 days and did a lot of testing, or whether you kept the patient for 2 days and limited the amount of testing, you only got that one allotment of money. So it was quite a radical change, and hospitals were challenged to try to manage that. At the same time, a social economic phenomenon was occurring in all the cities along the East Coast, and probably elsewhere in this country as well. People were leaving the inner city and moving out to the suburbs, flight to the suburbs, and the growth and popularity of the suburban lifestyle. So this happened here in Baltimore, and there was a suburb in the north that did not have a hospital, but it was a booming suburb, tremendous growth, and the board of directors of this hospital at that time said, "Gee, hey, we could do really well out there. It's a growing community, a great payer mix. Hey, let's move out there." So they actually purchased a 10-acre plot of land. They drafted up architectural plans to move the hospital. I've seen the plans. They're so detailed. You can see where the light sockets were going to go in each of the rooms, and for all the world, the hospital was going to move there. But the mayor came and knocked on our door. The local representatives of Congress knocked on our door and said, "Gee, what's going to happen to the citizens in this area if you all leave?" Mm-hmm. So the board of directors met, and they came to understand that, yes, indeed, we have deep roots here. We have a commitment to these communities. They decided to stay, and so the hospital did, and it struggled along, and in the 1990s was yet another challenge to hospitals all over the country, because in the 1990s there was the growth of a reimbursement system called the HMOs, Health Maintenance Organizations, and this was under President Clinton's administration. Now, President Clinton tried to pass a healthcare reform bill. It did not pass, but he was still able to institute policies that promoted the growth of HMOs. And what happened during that time? Well, HMOs were able to enroll tens of thousands of patients, and then they would go to hospitals. They would say, "If our patient gets admitted to your hospital, here's what we're going to pay." And the hospital had the option of signing or not signing those contracts. And if you did not sign their contract, then that HMO would say, "Well, thank you very much. We're going to go knock on the door of the hospital down the street." And then those patients would be admitted to your competing hospital and not your hospital. So hospitals felt compelled to sign these these contracts that were that did not pay well, and it adversely affected their bottom line. And so consequently, in the 1990s, many hospitals closed. That happened all over the country. And so how did this is a very difficult time. Many hospitals went in the red. These were very austere times for hospitals in the U.S. So how did hospitals respond? They joined together and formed a system. Up in Boston, for example, Mass General merged with the Brigham. Now, up until that time, the people from those two hospitals, they would not even be in the same room together. But they became one health system, the partner system. In New York City, and it's still going on now. There's multiple systems of hospitals. And it's hard to keep track. You need a general ledger which hospital now is joining which system. And so here in Baltimore, in Philadelphia, I think at the beginning of that decade, there was something like 20 independent hospitals. At the end of the decade, there were 3 hospital systems. There was the Penn system, the Jefferson system, and then the Temple Allegheny system. And you're going to wonder, well, what's the value of having this large system? Well, if a hospital system if a hospital system controlled all the hospitals, say in Western Philadelphia, and the HMO knocked on the door of Penn and said, "Hey, you got to sign this contract if you want to take care of our patients," and Penn said, "No, we refuse," and then none of the patients who live in West Philadelphia would not be able to go to a hospital in their neighborhood, and they would have to go to another hospital 10 miles away. That would not work. So then these HMOs were forced to negotiate with these hospital systems and create a more favorable contract that these hospital systems would sign. So the same thing happened here in Baltimore, and this hospital became part of the University of Maryland medical system. All right, so let me tell you about University of Maryland. University of Maryland is now, began as one hospital located in downtown Baltimore. It was built about 200 years ago, more than 200 years ago, and it was built to take care of the citizens of the state of Maryland. It was a state hospital. Now, back then, 200 years ago, people who lived in Maryland lived around Baltimore, and one hospital would do the trick. The hospital created a medical school 200 years ago to graduate doctors who would work at the hospital and take care of the citizens of the state of Maryland. Well, over time, of course, people moved away from the downtown and from the Chesapeake Bay, and they populated the state of Maryland. And so the University of Maryland said, we got to, in order to meet the mandate of trying to provide medical care to all the people in the state, the University of Maryland began to acquire hospitals all over the state. So if you go on I-95 North up to Philadelphia, along the way, you'll encounter Upper Chesapeake Hospital, which is part of the University of Maryland. If you go to the south, near Baltimore Washington Airport, there's Baltimore Washington Medical Center, and that's part of the University of Maryland. There's St. Joseph's Medical Center, which is a large multi-specialty hospital north of Baltimore in a suburb called Towson. If you go 3 hours due east from Baltimore, you'll fall in the ocean. But in that area that's east is called Eastern Shore, and there's a hospital in Eastern Shore called Shore Regional Hospital, and that's part of the University of Maryland. Recently, there's a hospital. They built a new hospital in Prince George's County called University of Maryland Capital Regional Hospital, and that's still in the state of Maryland, although it's pretty close to Washington D.C. So altogether now there's about 13 hospitals in the system, and the largest hospital is still the University of Maryland Medical Center located downtown. And the model is that the University of Maryland downtown is the sort of the mothership, the tertiary referral center, and then the other hospitals are sister hospitals that when they need patients when their patients require tertiary care, then they'll send the patients to the downtown University Hospital for tertiary care. And you'll say, oh, well, that's nice. Well, why do they need this hospital? We're less than a mile away. We're just 0.8 miles north of the medical center downtown. Why would they want to acquire this small community hospital just up the street? Well, here's the rationale. As I mentioned, the the University of Maryland Medical Center and the medical school have been at the same location in downtown Baltimore for over 200 years. Like all medical centers, like all medical schools, it wants to grow and expand. But they have difficulty doing so because of its downtown location. Land and property are expensive in a downtown location. But the University of Maryland has been expanding. There was a time when shock trauma was simply a set of beds near the ICU. Now, shock trauma is a hospital unto itself. The University of Maryland had to acquire a block of land. It built the shock trauma center. It has its own ORs. It has its own beds. It has a landing pad on the roof for the helicopter to land and bring patients there who need trauma care. It has an auditorium. It's a state-of-the-art trauma center. In fact, it was, I think, the first trauma center in the country, and its model of trauma care has set an example for the rest of the country in terms of being able to provide fast, accessible trauma care to all the citizens of the state of Maryland, and yield positive patient outcomes because of the rapidity with which they could get patients from their point of trauma to the OR, to the medical center, and get them the care that they need. All right. So that was expensive. The taxpayers of Maryland had to pay the bill for shock trauma. The School of Medicine also wanted to build a big research building. They had to buy a block of land. They dug a huge hole in the ground. I watched it being built. It was amazing. A huge hole in the ground. They built a 27-story research center. Now it's they spent $110 million on that building. And it's a state-of-the-art research center, and it's attracted researchers from all over the country to come join University of Maryland in meeting its research mission. All right. Now, the Department of Medicine, it doesn't have those kinds of money at the downtown medical center. So when the state acquired this hospital, the Department of Medicine began to shift its clinical services up to this site. So endocrinology moved its clinics up to this site. Infectious diseases moved its clinics up to its site. Sleep center moved up here to this site. Pulmonary clinics moved its clinics up to this site. So by offloading these clinical services to this site, the downtown site can continue to grow and expand. And so that's been part of the growth of this center here since it became part of the University of Maryland Medical System in 1999. And since that time, there's been a tremendous growth here at this center, at the Midtown campus, because of the increased volume of clinical services that are now being provided here. The ORs, for example, at the downtown site are busy, crowded, hard to get OR time. So the surgeons from downtown began to do their elective surgeries at this site. They were able to access the OR. Patients like coming here because they could get in and out of here pretty much more easily than going downtown. And in fact, to accommodate the increased volume of surgeries from downtown surgeons, we built an eighth OR a few years back. It cost over $1 million to put in a new OR. I think it must be the music system. But at any rate, the surgeons have told me that they like coming up here. It's the OR time, the availability of equipment, the staff. It's accessible, and the patients enjoy coming up here and getting the surgeries done here. So we've had tremendous growth here, and in 2015. The two hospitals formally merged into one medical center with two campuses. The board of directors merged. There's one CEO. There's one faculty that goes back and forth between the two campuses. And so essentially, this campus has become part of the University of Maryland Medical Center with essentially one mission and one CEO, one board of directors. Now, we've had tremendous growth at this center, as I mentioned. We now serve about 130,000 patients annually, both inpatient and outpatient. As I mentioned, there's a new state-of-the-art operating suite. They renovated the ICU here, and it's an 18-bed ICU. It's staffed by University of Maryland Pulmonary Critical Care faculty. They come here, they staff it, they teach our residents. There's 158, no, I'm sorry, I apologize. There's 58 pulmonary critical care faculty at University of Maryland. And what they did was to identify a handful of them who would come here and be here on site, rotate through our ICU for 1 week at a time, teach our residents, give noon conference to our residents on pulmonary critical care topics, serve on committees of the hospital, and essentially become our pulmonary critical care faculty. And this model has really worked out well because those faculty really get to know our residents. They get to know our hospital, our policies, and they will help mentor our residents who are interested in pulmonary critical care. They will help them get rotations at the downtown campus. They might introduce them to faculty who are conducting research in particular areas, and they will help mentor them in terms of maturing their interest in pulmonary critical care, if that is their interest. The new sleep lab, a sleep lab was renovated. It's now here. And a pulmonary rehab program was created, and it's now housed here. And then in 2018, they totally renovated the psych unit here. The psych unit is a 36-bed inpatient psych unit. It's a state-of-the-art unit. People come from all over the country to visit it because everything is organized in a way that patients will not be able to harm themselves. It's pretty ingenious. When I visit the unit, there's things that they do that I had never thought of and thought that you needed to do, but it's a lot of thought and effort went into creating this unit, and I think it's the largest psych unit in Maryland. And then in 2021, a new 10-story ambulatory tower was built on our campus. This is and I'll say a little bit more about that, but it's a wonderful new facility. Now more faculty are coming up here. If they're, because their clinics are here. And so more and more what's happened is that we've transformed into one large academic medical center with two campuses, between the Midtown campus and the downtown campus. The only difference is that we have separate residency programs, simply because the downtown campus is a large residency program, and we have a smaller program. We've kept the two programs separate for now. So this is the ambulatory building. It's up and running. The endocrine clinic and the nephrology clinic are on the 8th floor. GI, cardiology, and I apologize, I can't keep them all straight. GI, cardiology are on the 9th floor. Ophthalmology and ID are on the 7th floor. All right. Anyways, all I know is for sure the resident clinic is on the 10th floor. That's the top floor, and it's a beautiful facility. The residents enjoy it. There's a large conference room there. And you'll see it on the tour video if you can access it. Now, why build this building? And the building is so that it can help provide chronic disease management for the patients in our community. So if you have diabetes, you can come to the clinic, you can see the endocrinologist, you can see your primary care doctor. If you have diabetic nephropathy, you can see the nephrologist. If you have diabetic retinopathy, you can see the ophthalmologist. And so it's one center with all these different specialty areas. And our goal is to be able to provide patients all the care that they need as an outpatient here in this one facility. It's been up and running for the past 3 years now. We're very proud of it. It's functioned well, and there's coordination between the different clinics, so we can get patients subspecialty care in different subspecialty clinics, and yet have it be sort of all located under one space, with primary care being overseeing the overall care of the patient. This is the picture of Dr. Mohan Santha. Dr. Mohan Santha is the CEO of University of Maryland Medical System, so all 13 hospitals. He's a wonderful physician. He's a charismatic leader. He's a radiation oncologist in his prior career. Mohan still does a little radiation oncology. Of course, he's pretty busy sort of running the whole system, but he's proud that he's still a clinician at heart. But his strategic vision is that the two campuses are such that the university downtown campus provides tertiary care for all the citizens of the state of Maryland, and then this medical center, Midtown, provides chronic disease management and hospital care for those patients who reside in our local community. So I think those are not entirely separate missions, but when you meld those two missions together, we feel like the University of Maryland Medical Center, with these two campuses, are poised to be able to provide the care to our community, also provide care to our state. Now, our residency program. The goals and mission is to allow each resident the opportunity to create and fulfill his or her professional goals. We want to establish a clinical learning environment in our hospital characterized by collegiality, engagement, and a passion for scientific inquiry. We're a smaller hospital, certainly smaller than the downtown hospital, and we feel like our residents have a significant role in terms of nurturing this clinical learning environment. The residents, an important value of our programs, the residents teach and support each other, and we are proud that we provide high-quality, evidence-based patient care delivered in a compassionate, professional manner. So I know that this is somewhat abstract, but these are our aspirational goals. This is the goals for our program and for our residents. Let me introduce you to our program leadership and our faculty. So I'm fortunate enough to serve as the program director and the chair of medicine. Dr. Marciniak, who's a pulmonary critical care specialist, she's an associate program director, and this is her. And she she does weeks at a time in our ICU. Jeff Gerbino is also an associate program director. He's one of our preceptors in the resident ambulatory practice, and he's outpatient based, and so he's focused on the outpatient side. He's responsible for the ambulatory curriculum, whereas Ellen is more inpatient oriented, particularly with a focus on the critical care. Dr. Malik is our DIO, designated institutional official. Every teaching hospital has a DIO. They report to the ACGME, and they oversee the institution, the hospital, making sure that the hospital adheres to all requirements of the ACGME. Now, I'd like to introduce you to a little bit to our faculty, just to give you a sense for the faculty and how they work related to the two campuses. So in cardiology, here's Dr. Hawk, and he's been at this hospital for, I guess it's about 13 years now, 13 or 14 years now. He's 100% based here. He has a clinic at the ambulatory center. He follows patients in cardiology clinic. He also conducts consult rounds here at our hospital. So he's 100% here. Now, there's another cardiologist who is with him, Dr. Daryl Rubin, and Dr. Rubin is also 100% here. So between the two of them, they cover the clinic, they cover inpatient consults, and they provide the teaching for our residents in the area of cardiology. Evelino Vercelis is the division director in pulmonary and critical care. He's does weeks of service on our ICU for our residents. However, he's not 100% here. He has a research lab at the downtown campus in pulmonary and critical care. But he also has his clinic here in the ambulatory center. So he's here about 50%, 60 to 50% of the time. He often goes back and forth. There's a shuttle that goes back and forth between the downtown campus and the midtown campus. It runs every 15 minutes. He told me he's best friends with the shuttle bus driver because he's on it so much. Dr. Onder is the director of nephrology. There's about 4 or 5 nephrologists. So there's a big division of nephrology at University of Maryland, but there's about 4 or 5 who are help Dr. Onder rotate for weeks at a time on the consult service in the hospital, but they also see patients in the clinic who need nephrology consultation. I think residents have really enjoyed working with Dr. Onder. A tremendous amount of energy and enthusiasm. Dr. Kavita Kaura is director of hematology oncology. Now, Dr. Kaura did her residency here, did her hematology oncology fellowship at the downtown campus, and then she opened up an office here on our campus. She's been practicing here for almost 20 years. She has a senior resident rotation in her office so people can learn outpatient hematology oncology. She also conducts inpatient consults. She also directs the cancer conference. There's a lecture on a topic in oncology every month, and she runs that. So very active in our residency program, very active in our medical staff. Ray Kim is the director of GI. He has a sort of scared look on his face. And the reason why he's got a scared look on his face is because he'll be actually moving on. So he took on a leadership position at the downtown campus, and there's a new person who's going to come here, be the director of GI. I think starting in January. She's coming from Johns Hopkins, and she's looking forward to working with our residents and taking over the directorship of the GI division, the GI curriculum, and helping residents with maturing their interest in gastroenterology if that's what their desire is. Pat Ritzkavich is a director of ID. ID has a big presence at University of Maryland. It's one of their pillars of excellence. Big ID division. Institute for Human Virology, IHV, is a large research institute located at the downtown site. The Division of Infectious Diseases has a research portfolio of over $250 million, and they're great clinicians, wonderful to work with. Anyways, Pat and his colleagues staff the ID clinic. They also will perform consultations in the hospital. Great group of faculty to get to know. Continuing on, Dr. Munier is the director of endocrinology. He's a wonderful mentor and educator and clinician. Dr. McDashie is the director of rheumatology. Both of these folks are also the director of endocrinology and rheumatology, respectively, at the downtown campus. So they wear two hats. One is the director of their division here, and also director of their division at the downtown campus. The geriatrics is based at the VA, and Jake Blumenthal is director of the geriatrics curriculum. All third-year residents rotate at the Baltimore VA in geriatrics with Jake and his group. It's a well-thought-of rotation, and there's a lot of focus on learning geriatrics during that month. The emergency medicine curriculum is run by Dr. Afra Ali. She's a faculty in emergency medicine. All interns rotate through the emergency department for 1 month at a time. So Dr. Ali runs that rotation. She makes sure that you get a breadth of clinical exposure. And there's a set of lectures that you go to, emergency medicine, every Wednesday morning. It's a well-thought-of rotation. She's a very energetic and very passionate educator. Her specialty is simulation, and she enjoys teaching using simulation. Palliative care is Dr. Alexander, but she's retiring, and the palliative care services from downtown are coming up here and assuming palliative care consultation services here at the Midtown campus, and we're going to hear more about who is going to do that. So that will be a change that's coming. But we're celebrating Dr. Alexander's retirement. She's been at University of Maryland for almost 30 years in different roles. Okay, so talk about the call schedule. By the way, I don't know who these crazy people are. They snuck their way into the presentation. Okay, so the call schedule, there's 3 ward teams. On 2 of the teams, there's 1 resident, 2 interns. On 1 of the teams, there's 1 resident, 1 intern. And there's 2 medical students on each team. Now, the team with 1 intern and 1 resident, that's the intermediate care unit. That's it's a smaller team because there's a smaller number of patients. Let me show you. And there's a night flow team, that works from 7 p.m. to 7 a.m. They consist of 1 resident, 1 intern, and 1 medical student. And in general, the teams sign out to the long call team at about 4 o'clock. And the long call team is here until 7 o'clock. And then at 7 o'clock p.m., they sign out to the night flow team. And the teams rotate being on long call every 3 days. So here's a mock-up of the way that the teams look. And the purple and gold teams are resident. These are resident ward teams. They cap at 16 patients. So the maximum that an intern might have on their service is 8 patients. Sometimes they're at 16, but I see them sometimes at 12. I see them at 14, but never more than 16. Now, the orange team caps at 7. The reason why the orange team is less is because they're the intermediate care unit. These are patients who are too sick for the regular floors, but they're not quite sick enough for the ICU, and so they call this intermediate care. there's a lot of patients with COPD exacerbation, for example, and they're on high flow oxygen or they're on BiPAP, and they need close monitoring. People with mild DKA, people with heart failure, and that's somewhat tenuous. So these are people who need a little bit more closer monitoring than the regular ward teams. Now, between the purple and gold teams, they accept patients in a serial fashion. The cap of 16 and cap of 17 on the orange team. The night float admits a maximum of 5 patients overnight, and then at 7 in the morning, they transfer these patients over to the day teams. Now, the teams take turn being on long call throughout the month. They take long call every 3 days. The teams will have either Saturday or Sunday off. And to make that happen, a transitional year intern each month will work. They have a rotation where they work on the wards Friday through Sunday, and they help manage a ward service, and then they have Monday and Tuesday off. So that's a rotation for them. And by having them there over the weekend, we're able to give the interns make sure everyone gets 1 day off a week. Now, the yearly schedule has changed this year to a schedule of 13 blocks. Each block is exactly 4 weeks long. Before, we used to have 12 blocks, each block 1 month long. But as you know, the months vary in duration. So this is more predictable in the sense that every block starts on the same day of the week, it ends on the same day of the week, and it's exactly 4 weeks long. And so the total number of calls, total number of weekends, it's the same block by block by block. Here's the daily schedule if you're on the wards. So the day starts at 7 in the morning. You get sign out from night float. Then you conduct pre-rounds. I'm not sure exactly what that is. I see some residents walking around drinking coffee, but I guess they get familiar with their patients. And then at 9 o'clock, there's attending rounds with a hospitalist. And then at about 10:45, there's interdisciplinary rounds in which they round on their patients with social work and case management. And that noon conference every day. And then at 4 o'clock, there's sign-out rounds to the long-call team. Now, on Tuesday mornings at 7, there's a case conference. We encourage residents to attend. Depends if they're busy, then they're certainly excused. We try to encourage them to attend. It's a nice conference. All medical students attend it, and a case is presented by one of the interns. Okay. Now, here's the first year schedule. I'd like to go through it a little bit, and then I'll summarize it at the end. So there's 13 blocks. Each block is 4 weeks long. So there's 4 blocks of wards, 1 block of night float, 2 blocks of ICU. The ICU-CCU is a combined unit here. 1 block of endocrinology, 1 block of emergency medicine. It's an ambulatory block, and then 2 electives and 1 vacation. So there's 4 weeks of vacation. The ambulatory block, you rotate through surgical subspecialty offices. So ENT, urology, orthopedics. So you rotate through various subspecialty offices. I'll say more about the other rotations later. Now, we have a transitional year program here, and I want to mention that I want to mention them only to say that their schedule is very much similar to the categorical internal medicine schedule. They have slightly fewer general medicine wards, but they have this cross cover month in which they work on the wards on Friday, Saturday, Sunday to help out the general medicine interns, so everyone gets 1 day off a week. They get Monday and Tuesday off. Wednesday and Thursday they do ambulatory, so they meet their ambulatory requirement by rotating in clinics on that cross cover block. General surgery is something that the transitional years are required to have. They have an ambulatory block, but I only share this with you to give you insight that our interest is to have the transitional year schedule, have the transitional year requirements, have the transitional year responsibilities be similar and mirror those of the categorical internal medicine intern schedule. Because our view is that we have one internship group. They are all in the same boat. They're all pulling together. Our interest is that we have one confluent group, and I think that will make the internship go smoother and develop a greater sense of community and collegiality. Because as you know, if everyone in the boat pulls with the same vigor, pulls with the same amount of strength, then the boat will go in the right direction. You like that? Okay, I'll do it again. Watch. Whoop. All right. Well. All right. Yeah, there it goes. See, that's pretty cool, right? I worked for a while to make that happen. All right. Anyway, and I think it happens. The transitional year interns, they have the same requirements in terms of what they do when they're on the wards. And so, if you ask the nurses, you ask the faculty, is this a transitional year intern or is this a categorical intern? There's no one will know the difference unless you happen to talk to the transitional year intern and they tell you they're a transitional year intern. Everyone's held to the same standards. And we have 10 transitional year interns. We have 9 categorical interns. And so we want them to gel together to form one group. And I think for the most part, it happens. We try to work towards that end. I was fortunate enough a few years ago to attend a wedding of one of our categorical residents. After he graduated residency, he got married. And at the wedding, there were just as many transitional year interns with whom he did internship with as categorical residents with which he did residency with. Because during internship, you form close bonds with your co-interns, and you form close bonds with the transitional year interns as well as with your own categorical colleagues. Second year. All right, so this is the picture of the ICU, and this is them at night. And I thought they worked hard at night taking care of the ICU patients, but look, this is what they're doing. They're sitting there eating pizza all night. Okay. Anyway, this is the schedule for the second years. 3.5 blocks on the wards. One block is a quality improvement block. That is a month in which you work on a QI project. You work with our QI quality improvement department. You get mentored on developing a project, and you work on that project for the next year. And the expectation is that you complete the project by the time you graduate. And at the week of graduation, we have all the senior residents present their projects. And it's really exciting to see the projects that the residents have done and how they've contributed to improving care at our hospital. Some of these projects have been able to be published in the literature. And and disseminated to other hospitals, and it's so it's really great to see. There's 2 ICU blocks, one block of night float, one block of neurology. So that neurology block is located at the downtown campus. At the downtown campus, they have a neurology residency, neurology faculty, neurology grand rounds, and so it's a robust rotation. The residents have enjoyed that rotation. They get referred patients from all over the state with neurological diseases, some interesting conditions, and our residents have enjoyed that rotation. So ambulatory block here is primary care. So whereas the ambulatory block in the first year was subspecialty, surgical subspecialty offices, the block in the second year is primary care. You have 2 electives and 1 block of vacation. During the second year, I think the transition from first year to second year is a much more challenging transition than from medical student to intern. As an intern, you always have oversight, you always have backup, and it'll be the resident. As a second year resident, the expectation is that you are in charge of the service. You're given a responsibility for managing the patients on the service. You have autonomy and accountability to the degree that you feel comfortable. There's always backup, but we want the residents to feel like that they have the decision-making authority to manage their cases. I want them to feel like they can develop and mature their own clinical style and approach. So there's increased responsibility for them. They're also expected to teach and mentor the interns and the students on the service. And that is an important role. My hope, my aspiration is that when all of our residents graduate, that when they graduate, they will look for opportunities to be involved in teaching. And that teaching was one of their core skills. And whether they teach medical students, they teach residents, they teach other doctors, that teaching is part of their core values and skills when they graduate. So the second years should be making the transition from following orders to giving orders. Here's a third year schedule. There's 1 month on the wards, 2 months of ICU, half block of night float, half block of nephrology. And this is a nephrology clinic. I think what we came to learn is that if you just to the inpatient service, that you see a lot of patients with end-stage renal disease, and they're on dialysis, and you think that nephrology is managing patients on dialysis. But nephrology is really a challenging subspecialty, and the purpose is to manage and treat patients with chronic kidney disease to prevent them from going to dialysis. And the residents who do the nephrology clinic, they have found that the clinic experience is more diverse in terms of the exposure to pathology than the inpatient service. And there's a different set of skills and medical knowledge material that they learn during that rotation. It's a 2-week block. There's 1 month of geriatrics, as I mentioned. It's based at the VA. There's 1 ambulatory block here, and you're going to say, well, what is that one? And that block is up to you. You can pick a subspecialty area that you're interested in, and you can do ambulatory block in that area. If you're interested in GI, you can do GI clinic. If you're interested in cardiology, you can do cardiology clinic. So it's there's options there. Now, you notice that rheumatology is a required rotation in the third year, and endocrinology is a required rotation in the first year. Why do we have that? Um, I feel like those two specialties, to really get your hands around those two specialties, to learn the medical content in endocrinology and rheumatology, you pretty much have to go to the clinic because that's where the patient care is mostly housed. There's not a lot of rheumatology or endocrinology in the hospital. It's mostly outpatient because the diseases are mostly outpatient oriented. So we felt like to really know those two subspecialty areas, you got to do those rotations. So we've mandated those rotations. They basically function like required electives. I know that's an oxymoron, but we require endocrinology and rheumatology for residents because we feel like they have to know that material. And the best way to know that material is go where those patients are, and that's in the clinic. Now, sort of following that same philosophy, we've required a HEMOC outpatient rotation during the third year. This rotation is interesting because you see in the hospital, when you see a patient with cancer, these are patients who are more advanced in their cancer. They're suffering because of it. But nowadays, a lot of people with cancer are surviving their cancer. They're doing well. They're working, and so when the residents did this rotation, they got to learn about cancers that are largely treated as outpatients. They get there's an infusion center at that site, and they get a broader spectrum of different types of cancers, including bone marrow type cancers, and also they see a good deal of hematology, a little bit more hematology than what they see in the hospital. So it's been a good rotation, and residents have enjoyed it. Now, in addition to 3 electives that residents can choose, there's one cardiology rotation that's based at the downtown site. Why is that? Because here at this site, we don't have angioplasty. We don't have bypass surgery. So, for example, if you come to our hospital and you have acute coronary syndrome, we call it Uber for you. No, we don't call it Uber for you. We send you to the downtown campus, and there you'll get your angioplasty, your stent, you get your coronary artery massaged, whatever it is they do, and so that patient population, those procedures are available at the downtown campus and not at this campus. So we have mandated a rotation at the downtown campus in cardiology, so residents get exposure to invasive cardiology, to acute coronary syndrome. Now, there's a second message here, and what is that? If you're interested in interventional cardiology, this probably is not going to be the best site for you. You're not going to see these patients on a regular basis until you do that rotation. The downtown site would be a better location for you. Okay, so I've summarized the general medicine wards, ICU, ambulatory blocks, the night floats, and the elective rotations here. I mentioned about the different types of ambulatory blocks over the 3 years. I mentioned that endocrine and rheumatology are required electives, if you will. The QI block is it's mostly a library-based rotation. You're working on your QI project. Neurology and cardiology are located at the downtown site, and geriatrics is located at the VA. So residents have to do at least 2 rotations at the downtown site. Many of them do more. They can pick and choose other elective rotations to do downtown, depending on your interests and preferences. This is the downtown Inner Harbor area. You can park your boat in the Inner Harbor and visit the sites. Okay, the clinic. So the clinic is a continuity clinic for all the residents for all 3 years. We have Epic in the clinic and Epic on the wards. We have this arrangement. It's sort of a hybrid X plus Y kind of schedule. There's no clinic when you're on the wards, ICU, night float. But when you're not on the wards, ICU, or night float, or vacation, then you have 2 sessions per week. So basically, non-call rotations, you have 2 sessions per week in the clinic. So the total number of clinic sessions over the 3 years is meets the ACGME requirements. You're supervised by full-time general internal medicine faculty. I mentioned Dr. Gerbino. He's the associate program director. He's one of the faculty supervising residents in the clinic. They utilize the Yale ambulatory curriculum, which is a case-based curriculum, and a different case is presented every week from the Yale ambulatory curriculum. And this is a session that's held at the beginning of clinic from 1 to 1:30. And by going through all the cases in the Yale curriculum, you'll have covered general internal medicine very well, so it's a good review. In terms of our medical conferences, there's all the subspecialty areas are covered in our conferences. How do we do that? So we take Harrison's textbook of medicine. We tease out all the topics in Harrison's, and then we make sure that each of these topics are covered. It turns out that we can cover all the topics in Harrison's about 1.5 years. So basically, we repeat the curriculum twice over 3 years. You're not going to go to every conference because you'll be on night float, you'll be on vacation, you might be doing a rotation at the downtown site. So, but we hope that by giving the curriculum that lasts 1.5 years and then repeating it, that over the course of 3 years, you'll have a chance to hear most of our subspecialty lectures. There's a case conference, as I mentioned, every Tuesday morning at 7 in the morning. Once a month, there's an ambulatory presentation on an ambulatory topic. This is given by the residents who are on ambulatory block. M&M is twice a month. The Journal Club is once a month, and Grand Rounds is twice a month. Journal Club is interesting. We have a Journal Club. It's a written document. It's a manuscript. Residents have to submit a review of a journal to the Journal Club journal, I guess. It's published every quarter, and the reason why we do that is because we want residents to be reading the journals, and you submit basically a review of the journal, and then every quarter that's published. Now, in addition to that, once a month we have a lecture in which a second or third year resident presents a article we discuss in detail. And that's a rich discussion. This is the simulation lab at the downtown campus. We have access to it. We have a simulation curriculum. We also have a smaller simulation lab here at this campus, and we do use that as well. We have mock codes. The downtown campus is a little bit more robust in terms of the equipment that they have available. So we have point of care ultrasound. This is the machine that's in the ICU. This is the machine, not this person standing next to it who thinks he's a machine. We also have a nice ultrasound machine in the emergency medicine department. The emergency medicine faculty are all quite facile with point of care ultrasound, and they enjoy teaching our residents how to use it. And then we purchased 2 smaller devices for the wards, so the residents on the wards have access to it, and they can learn how to use it. We did have a point of care ultrasound curriculum. Um, it's the challenge has been to train our faculty to be skilled in doing it, and then for them to teach our residents. But at nighttime, we have a emergency medicine physician in-house who's on call for emergencies such as rapid responses and codes and intubations. And that emergency medicine doctor will often teach residents on the night float rotation about using point of care ultrasound. There's a fair amount of downtime during the night, and that's an opportunity to learn ultrasound on the patients who are admitted that day. What we're not. We're not a fellow-dominated program. We do have fellows here. There's a pulmonary critical care fellow who is housed in the ICU, and they help residents with procedures. They help residents with intubation and managing the patients in the ICU. They're very helpful, and our residents enjoy working with them. And each year they honor one of the fellows by giving an award to the best fellow. There's also a ID fellow who helps out with the ID service. But in general, it's when you call for cardiology, it's a cardiologist who comes to your patient. It's a cardiologist that you'll talk to, you get to know. When you call for nephrology consult, it's a nephrologist who comes to your patient. The nephrologist will talk to you, you get to know them. And so it's not a fellow dominated program. They won't be stealing procedures from you. The fellows, in fact, are there to help train residents on doing procedures if that's your interest. There's no requirement to do procedures, but if you're interested, they'll be there in the ICU to help you with that. We're not a medical school here at this site. The University of Maryland School of Medicine is located at the downtown site. They do rotate here. The purple team, we have 2 University of Maryland School of Medicine students who are doing their clerkship here. Because we are not able to populate all of our ward services with medical students, we have an arrangement with American University of Antigua to put students on all of our services. I think that's important. I think it's critical that the residents have a student on the service. It changes the climate of the team. Changes the focus. It puts the resident in the position of training and mentoring, educating the students. It makes a big difference when there's a student on the service and when there's not. So the ICU team has students. Some of the elective services have students, and I think this is important, not just for the student, but for our residents. We don't have on-site research labs here. There's no intent to bring research labs up here to this site, especially since they built a large research building at the downtown site. However, our residents who are interested in conducting research, they do have the opportunity to seek out those opportunities, to speak with the faculty who do bench research, as well as clinical research, and gain mentorship and support for research. We don't do bypass surgery here. We don't do transplants here. If those are your interests, this may not be the right fit for you. Now, we don't have subspecialists in every field. What do we mean by that? So we have cardiologists here, but we don't have left atrium specialist. We have patients with heart failure. They're managed by our cardiologists, but we don't have subspecialists who all they do is advanced heart failure. If patients have refractory advanced heart failure, then they get sent to downtown, and there they'll have subspecialists who will get them ready for an LVAT, get them ready for transplant. Those types of services are not available here. Similarly, we have gastroenterologists here, but we don't have pancreatologists. Now, if we have a patient with advanced cirrhosis, we send them to downtown. They have a liver center there. They have hepatologists stationed there, and they have one of the largest liver transplant programs in the country. But those transplant services and those physicians associated with transplant are not going to be based here. Residents can access those specialists and access those that patient exposure by rotating on those services at the downtown site, but not at this site. So what's unique? I think our program's been here for over 60 years. It's highly valued by the institution. The hospital is very proud of the residency program. I meet with the CEO of the hospital regularly. They always ask about how the residency is doing. What can they do to help? And so that degree of support is not always universal around the country. Secondly, our philosophy is that I want this to be a resident-run program. It's much more fun. I feel like I'm sitting in the back of the bus. I want the residents to be driving the bus, finding initiatives for us to pursue, and moving us forward. So for example, I'm not an expert in point-of-care ultrasound. I wouldn't even know how to turn one of those machines on. But the residents had an interest in it. They developed a curriculum. They identified faculty. They came to me when they needed funding because we needed to buy a couple of ultrasound devices. We were able to look under some mattresses and found some money. Those things are not cheap. In fact, one little ultrasound machine costs more than my car. Of course, I don't drive a fancy car, but at any rate, we able to. We got 2 ultrasound devices for the wards, and residents can use them. Similarly, one of the residents was interested in simulation, created a simulation curriculum, and we were able to utilize the simulation lab at the downtown campus. In fact, the director of simulation at downtown campus told me that our residents use it to a greater degree than the downtown residents use it. We think it's a great resource. Other examples is wellness. We had some residents interested in wellness. They created a wellness initiative. Again, I'm not an expert in wellness. I wish I was. But they identified a faculty member who has that interest, and we have a wellness committee. So the message here is that you as a resident can make a difference, and you as a resident should make a difference. And at the end of your residency, we want every resident to look back and ask themselves, hey, did I make a difference to this hospital? Did I make a difference to the program? And I hope that you will. And I hope that that's an approach you're going to take as you go on your career, that as you go on to whatever organization you join, whatever institution you join, that you hold yourself accountable to making a difference to those patients, to that institution, to the quality of care. That's a standard that you hold yourself to, and that should begin during your residency training. Lastly, there's always a balance between providing education and service. we feel that our residents are here for an educational experience. They're not here to provide service. They're not here as service workers uh, for our patients. Um, uh, if you go right now and you take our residents out of the hospital, our hospital wouldn't close. We have intensivists. We have hospitalists. The hospital was still run. Um, let me give you an example of this. According to the ACGME, the service cap on the resident service on the wards is 10. Interns cannot have more than 10, according to the ACGME. So we were never at 10. We were per intern. We would be so an intern, a service is equal to 2 interns. So the cap was 20 per service, but we were never at 20. We would be 13, 14, 15, 12. Never really got to 20, except suddenly we were at 20 every day during the pandemic. Oh my goodness. During COVID, we were busy. All hospitals around the country were busy, and we were at 20 for months. And I thought, okay, after this pandemic, things will settle back down to what it was, to our norm. Well, it didn't. What happened during the pandemic was that Baltimore, University of Maryland became a referral site, and the downtown campus, which has a lot of ICU beds, they were the COVID hospital. Non-COVID patients were being sent to our hospital, and so we were very busy but mostly with non-COVID patients. And then what happened was people found out all over the state that, hey, if you needed a hospital bed, send them to Midtown. And we were getting patients from all over the state. It's been a learning experience, and because it's interesting to get patients from all over the state. It's a wider diversity, a wider set of pathology. But at any rate, the resident services were busy. So I said, let's reduce the service size from 20 patients down to 18 patients. So we did that. The residents were happy, and but then they came back to me about 4 months later, and they said, well, 18 is good, but we're still busy, and we feel like we don't have the time and effort to learn from each patient. That our focus is on making sure that patients get the service that they need, get the clinical care that they need, but the educational mission was not being met to its fullest. So I said, okay, let's cut down to 16. So we reduced the service cap to 16, and now it was better. The residents are still busy. They are seeing a good breadth of pathology, and they have the time and availability to extract the educational experience from every patient that they see, because that's my goal, is that this is a learning experience, and each patient should be a learning experience. Okay, you'll say, well, that's nice. Each service now is only 16 patients. Where do those patients go? So each service is now down by 4, from 20 to 16. We can't just let those patients go sit there in the hospital without someone taking care of them, right? So the hospital had to engage a new hospitalist service, had to create a new hospitalist service to take care of these patients who are not on the teaching service, to create an additional non-teaching service. Now, hospice, if you know this, hospitals don't grow on trees. And to create an additional hospital, non-teaching hospital service, you basically need to have two hospitalists, one who works for 7 days straight, and then they're off for 7 days, and then there's a second hospitalist who works for 7 days straight. And so they rotate like this, 7 days on, 7 days off. So that requires hiring two full-time hospitalists. And so that, if you add up the bill for that, that's $500,000. But so I went to the hospital. I said, we're cutting down from 20 patients all the way down to 16 patients. That required the hospital investing, $500,000. But the hospital made that commitment because they realized that we don't want to compromise the educational experience of our residents on the inpatient service. So this little fella in the corner here, he's not one of our residents. Okay, but I'm often asked, what are we looking for in a candidate? And our philosophy is that residents are they're adults, they're adult learners, and adults are responsible for their educational experience. So we're looking for folks who have demonstrated that they have an initiative, they have intellectual curiosity, they have self-discipline, they have a motivation, and have the ability to motivate themselves. They're resourceful, they have drive, they work as a member of the team. Now, I know this is sort of abstract, but let me give you some examples. All right, so we had a resident who was rotating as an intern in the ICU, and he rotated in the ICU, and he worked with the pulmonary critical care faculty. And so he said to me, "Hey, I really enjoy pulmonary critical care. I think I want to pursue this further. Seems like a great specialty." So I said, "Okay, great. Talk to the faculty, and maybe you can do a pulmonary critical care elective at the downtown site." So he did, and he did a interventional pulmonary consult elective, and it rotated with the interventional pulmonologist at the downtown. Saw some interesting pathology, and in working with the pulmonologist there, they identified some patients that they thought would be interesting to write up, and so he wrote manuscripts and submitted them. He submitted them as posters for the CHEST meeting, and both abstracts got accepted for poster presentation, and so he went to CHEST. He presented his cases, and he won third place as the best poster presentation at the meeting. There were hundreds of posters at that meeting, and he came back, and he was invigorated regarding his interest in pulm crit, and so that's that was one resident's journey, but all the residents can give you a similar story. Some have decided to pursue infectious diseases. Some have decided to pursue cardiology, nephrology. Some have decided to pursue primary care. Endocrinology is a popular destination. So they all have developed different interests, but we want them to develop an interest on their own, use the resources that we provide to them. But it's not our job to push them, to steer them down any particular path. That they take the initiative and utilize their own motivation and passion to find their path. So at the end of the 3 years, each one will have a different path, a path that they negotiated themselves, a path that they can be proud of, and and leave their own legacy behind. Okay, when you graduate, you will have different options available to you. What have residents who've graduated in the past pursued? Some have gone to private practice, either working as a hospitalist in a hospital, working in general internal medicine. Some have gone on to fellowships. Some have gone to academic medicine. Let's go through some of the prior classes. So in 2019, we had one person go to ID, one person go to nephrology, one person go to critical care, one person in cardiology, one sleep medicine, which is based actually here at Midtown. The sleep medicine fellowship is based here at Midtown. One to GI, one in general internal medicine, and primary care out in California. In 2020, 4 people went to cardiology. Do we need that many cardiologists in this country? I don't think so. One person went to Pulm Crit, one went to endocrine, 2 went to GI, and one is still a hospitalist in Lawrence, Massachusetts. In 2021, one went to cardiology, one went to ID, one went to endocrine, one did the sleep medicine fellowship, one did GI, 3 went to primary care, and then one went to hospitalist medicine. I'm being a primary care physician myself, and glad to see folks going into primary care. That's I think that's a very worthy career destination, and something that you can find career satisfaction in pursuing, and never have a dull day in your life. In 2022, one person went to nephrology, one to cardiology, one to endocrinology, one to Pulm Crit, one to GI, and then 4 to hospitalist medicine, in various sites around the country. One of them is a academic hospitalist here, and we're fortunate to have him. In 2023, 2 people went to vascular medicine. That's a new growing specialty. It's a interesting area that's growing. And both of them are doing well. The one person went to endocrine, one person went to rheumatology, one at endocrinology, 2 doing hospitalist medicine, and 1 doing primary care. And then the group just graduated in June. One is doing vascular medicine up in New York. One is so he's practicing nephrology, because prior to coming here, he had already completed nephrology fellowship. So he did his internal medicine residency, and then now he was able to get boarded in nephrology and practice nephrology. 2 doing endocrine, 1 doing hospitalist, 1 doing hepatology fellowship at the NIH, 3 doing hospitalist medicine, and 1 doing primary care. So over the past 10 years, this is what the overall what things look like. Looks like the most popular destination is hospitalist medicine, but we have a good number going into general internal medicine, ID, cardiology, endocrine, GI, so different specialties, and it's nice to see it. For me, it's gratifying to see a nice diversity of interests here. Okay, now just a word about Baltimore. I know you're getting tired. I can see you guys nodding off. So I don't know if you've ever been to Baltimore, but the Inner Harbor area, a very festive area, especially in the summertime. There's a lot going on. And the Orioles are a baseball team. Oriole Stadium is about a mile away, just south of us. They were in the playoffs this year. They were in the playoffs last year. It's fun going to Oriole games. Ravens are our football team. great team. Lock it in. They're going to be the Super Bowl this year. Great team. We love the Ravens. The crab is the food of Baltimore. They're not easy to eat. You have to be very patient. There's a skill set involved there. Takes some practice. This is the Baltimore Art Museum. It's located about 4 miles north of us, and there's 2 nice art museums: the Walters and the Baltimore Museum of Art. Both are free to the public. So we have a soccer team. Now, the way that the soccer team works is we play the other residencies in Baltimore. Now, we're a small team. We're a small residency program, so but we have to compete against University of Maryland, which has 150 residents. We have to compete against Johns Hopkins, which has 160 residents. And here we have 36 residents, and we have to field the team and play them. So I told our residents, you got to practice and practice. Well, they said, yes, we're going to practice. Well, here's a picture of them practicing. I don't know how much practicing they're doing here. And then one day I asked the team, I said, hey, are you guys practicing? You're rehearsing? They said, yes, we're practicing our plays. I said, okay, great. How you doing that? They're doing that using Xbox. Okay, all right. They a lot of eating goes on after work, I guess. And this is in the call room, and a lot of eating goes on at work as well. They have some outings. This doesn't look safe to me. I'm here to report, though, that she was able to get out of there, and she survived the day. But I'm not sure that's a particularly safe thing to do. So there's a picture of our soccer team. They did not win. But they borrowed the trophy and they took a picture as if they won. But you have to admit, we have the best shirts. By far, these are the best shirts. Here's the following year, we had another shirt. They played hard. We didn't win, but I think we always have the best shirts. We have a medical Jeopardy team, and we compete against the other residencies in Baltimore. And in the past 6 years, we won the Maryland competition twice. So when you win the Maryland competition, then you go to the national and you compete there. Here was one of our teams who won the Maryland competition, and so they went to the nationals and competed there. So it's a close-knit community. They do a lot of things outside the hospital. Well, if you're not a Ravens fan, we'll convert you to being a Ravens fan. Now here, they all went out for dinner, which makes you wonder who was covering the hospital. What was going on at the hospital? This doesn't look safe to me. Right. So today, have a great experience. Interview with our faculty, ask them a lot of questions. We want you to walk away with the feeling that you have a sense for what the program is all about. We want you to, you can dial in on noon conference with our residents. There's a virtual tour video that we made, and feel free to watch that. Probably the most important part of the day is this session with residents. There's no faculty there. There's no one from the program there. The residents have been told that nothing that the applicants say or do will come back to the program. Also, nothing that the residents say or do will come back to the program. We want the process to be transparent. We want it to work for you, so you can cut loose with any and all questions, put the residents on point, and I want you to walk away at the end of the day with a true impression of what it's like to be a resident here. Our resident coordinator will go over with you what the benefits are. And I'm here to tell you that routine follow-up correspondence is not encouraged. Don't feel compelled. You have to write a thank you note. I don't want you to spend time and effort trying to figure that part out. This is a policy that's adopted by many programs around the country. We feel that's, we don't want you to be spending time getting involved with that. You all have much better things to do. So I'm going to wind up here. Want to thank you for your attention. Thanks for hanging in there. I know that it was a long, arduous. I hope that the coffee lasted for the duration of the of this session. Hope you gained an appreciation for our program. I hope that you come to the interview with a lot of questions, and we'll be glad to address them. But we feel that we are still in this transition mode of transforming from an independent community hospital that's now an integrated, large academic medical center. But we have a community hospital flavor, a community hospital feel. That when you come to our hospital, you'll know the security guard, you'll know the people in the cafeteria, you'll know the nurses on the floor. It's a small hospital, you get to know everyone, and it's a different vibe, a different atmosphere than a large medical center, which is like a big city compared to us, which is more like a small town. And I hope that you get that sense as you talk to our faculty and residents. So thank you very much, and look forward to meeting you. I'm going to sign off now. Bye.